right, welcome back to another episode of Paw Patrol with your host, Dr. Jeff Dykes. Today, I am joined by Dr. Alton Johnson. Thanks for joining me tonight.
Thank you guys for having me.
Yeah, absolutely. So, Alton, you did podiatry school at Kent State in Ohio. Then you did residency down at HCA Aventura in Miami, Florida. And then you did a research podiatry fellowship at the University of Pennsylvania. But now you're at the University of Michigan. Kind of take us on the journey of how you ended up from Ohio to Florida and then up to Michigan.
I know, right? So it all started. Thanks again for having me on the podcast. So it all started. I mean, when I first got into podiatry school, I think a lot of people get appealed and, like the surgery life and everything like that. And I was never one of those big wound care guys. I always thought that, the odors doing wound care rotation was kind of odd and everything. And then I get into residency and, you do everything. My particular residency was pretty heavy on trauma and wound care. Limb preservation type of cases. But I ended up spending time with this plastic surgeon, Dr. DeRosiers, when I was a first year podiatry resident there. And he always needed someone to do like his late night cases. Nobody else wanted to do it. He used to do this pro bono stuff. He was a pretty cool guy. He's still around in Miami. He used to wear double Rolexes and everything. And I was like, I just want to be like this guy. I was like, I figure if you could, be around money, you could smell like money. But all he would do is like this, when he come to our hospital, was limb salvage, diabetic wounds, wound vacs, split thickness skin subs, allografts, things like that. And that's where I learned it. And I learned how to do it. And I spent time with him. Then he also had a podiatry fellow that he ended up adding on a year later. So I would go to their cases and do it. So I spent 2 years with them just learning that stuff and not pretty much ancillary to my podiatry training there at Aventura. And then I was like, you know what? I want to do this like forever. Like I like this more than just doing like the trauma cases, hardware cases and all of that. So that's when I reached out to Dr. Scott Malay at the University of Pennsylvania, decided to do his wound care research fellowship. It's like a little bit more serious. I knew I wanted to go to academia, and I knew he could help me get into academia and navigate academia. So I ended up doing 2 years there. Actually got stuck there during the pandemic years, 2019, so 2020, 2021 time. So it actually worked out for me career-wise. Then ended up getting recruited out to University of Michigan and their academic program. Started off in the internal medicine program. Actually recently, I would say over a year ago, transitioned to the orthopedic department as the first podiatrist in that department, essentially as one of their limb salvage, because pretty much, the orthos, they want to do the sexy cases where the outcomes come out great. So they're like, all right, we'll have the podiatrists come in and do the nasty stuff, the amputations, the dirty cases. And I love it. It's great. Yeah, exactly. It's fun stuff. You never know when it's coming in, things like that. And I was actually able to bring another podiatric surgeon in. So it's actually two of us in the department, growing the department. So it's great.
Cool. So yeah, Dr. Malay, he was the editor-in-chief of the Journal of Foot and Ankle Surgery. So what was that like? Kind of what were you doing when you're out there in Philly? Yeah,
so what it essentially was, the main goals was to understand how to actually conduct and design clinical research studies, and also how to, write, critical writing, and then also learn how to run a practice, manage your post-op complications, and also run a wound care clinic. That was kind of your main responsibilities. But what I really grasped from it was how to truly execute research at a high level quality. And essentially, that's kind of bled over into my career path here at University of Michigan. I have 2 clinical research projects that I'm working on, and actually end up doing now more so into innovation now than straight up clinical research design, but kind of also doing that. But essentially, Malay, who's the, a guru at that stuff, he has a master's in clinical epidemiology, I believe. But essentially, he was the only clinical scientist in podiatry that had this, particular training on how to actually conduct and, design research studies that can get, high quality journals. We're talking about New England Journal of Medicine, things like that, which, more so than, even though he was the editor of JFAS, which he brought that that impact factor up very high, because he was learning how to discern which papers were going to, make this make this journal look successful and actually bring in quality studies, high level studies. So that's what it was. And so basically taught me how to navigate academia, how to get money, how to get grant money, because he actually never really dove into industry funds, but now I kind of do industry funding, but industry funded research, and basically learn how to get this grant, NIH money, NIDDK type of money to get, and CPME's money as well to conduct successful podiatric research and surgery.
So let's talk about that for a minute, because I think that's something that a lot of people probably don't understand very well, which is how to perform not just research, but high quality research. So
Yeah.
what are some of the tenets, the kind of the basic things, maybe for some of the younger people listening, that make a good research project when you're trying to come up with an idea and think, oh, maybe this could be a good idea, but taking an idea and then making it a reality is actually sometimes very complicated.
Tough. Yeah, it's
So
tough. So yeah, so when I thought I got there, I thought, he's gonna have like this ready-made pie and I'm just gonna be able to slice into it. It was like, nope. I had to go to the grocery store, not even grocery store. I had to go to the farm, pick the, sweet potatoes, pick the pumpkin and start, brewing these pumpkins and cooking them and making a sweet potato pie. So it's true.
yeah,
Like you could have the greatest idea. And, so my particular research on that one was, before, I wouldn't say before, but right when, when we realized, like, I don't want to brand name someone, but basically we realized the frontal plane importance of bunion correction. So the bunion is more so than that biplanar, transverse and sagittal plane motion. We're thinking about three-dimensional inverse plane and, things like that. So what happened was we started to look into the sesamoid position of it and looking at the frontal plane motion of the bunion, bunions that we did. So what we did was I was like, why don't we actually go back and see what was those sesamoid positions before we actually, did the bunion procedures versus afterwards, and seeing if we actually are correcting the bunion, or are we just moving the head of these, of these metatarsal heads, something like that. So start off with that great idea, and he's like, all right, so figure out how to design it. And I'm like, I thought this is what I signed up for fellowship for. Like, you're going to tell me what to do. But it's true. Like, you have to, it's kind of like that. It's like any other like sport. It's like, you have to go back to the drawing board and figure out what's the, what's already out there. So it's like, do I recreate the wheel? How do I kind of set myself apart from those studies? So that goes back to, how do you do it? First, you got to see if someone has already did it. It doesn't mean if someone has already did it, can you make it better? So that's how you do it. So that's what it was. No one really ever looked at the tibial sesamoid positioning in the frontal plane and things like that. So that's what we decided to go with, try to create like some type of classification system around that, which was semi-successful. But what it really did was teach me how to design these studies from a retrospective side, and then also thinking about prospective studies in the future on how to design it. I wasn't able to get too many prospective. The biggest thing with those studies is who's going to pay for the time, who's going to host it, who's going to host this database that has to be secured, who's going to actually go back and do the number crunching, and who's going to make sure the IRB is cleared and make sure you're updating the IRB on that. So and IRB is Institutional Review Board for the students listening, which any clinical research study has to go through, whether you get an exemption from it or you get a permission to execute a study, whether it's retrospective or prospective, meaning something that's already done or something you want to do.
Yeah, and depending on the complexity of the study, especially the number crunching, like you said, sometimes you need to actually involve a statistician. So we as clinicians can only go so far until the math gets too complicated for us and we have to involve some other people to help in that. So I think that's a critical aspect as well. But yeah, coming up with an idea, designing the study, saying, what are we looking at? What are we comparing? What are we trying to decide? Are we trying to, what's the end goal? What's our hypothesis of what we're trying to decide, and then enacting that. So I think that's fantastic experience, especially with Dr. Malay, who's had a lot of experience in that. And then you've put that to work too, because you're still pumping out lots of research where you are. So I think that was probably a really beneficial thing for you to spend that time there.
Yeah, exactly. A lot of my attendants thought I was crazy when I told them, I want to go into academia, I want to do this research and all that. But it was like, you got to always kind of know your personality traits. It doesn't fit everybody. And I tell people academia is not for everyone, because it's a lot of politics involved. It's a lot of rubbing of the shoulders, because you're trying to get funding. And if you're a junior faculty like myself, you can't necessarily apply for certain funding because you don't have that notoriety and they don't have the backing of those dollars. So you usually have to piggyback off someone, which that's everyone knows that. Even Malay had to do it to get his own funding. So it's just like, you have to do it, and then you have to play nice, and then eventually you'll be able to fund your own projects, which I think is going to be my next one coming up soon. Hopefully be in the next year or so.
Yeah, that's great. So you serve on the board of directors with the American Society of Podiatric Surgeons. How'd you get involved with them?
Yeah, so I'm actually the outgoing chair. I'm just completing my second year in as that role, actually end of December. So I mean, basically, I've always wanted to be active in the societies, whether it was, APMA, ACPM, or ASPS. So opportunity came where they had the board positioning opening. A lot of the board had aged out of it, meaning their terms were over. They have term limits. And so I applied to be eligible for the board. And then the next year ended up getting elected as chair of the board. Kind of was like, dropped on me, I was like, can I do vice chair first? They're like, nah, I think you can figure it out, which was probably one of the best moves I had made in my career, because it actually taught me how to be organized in both my personal and my professional life, as well as the society roles that I play. Because it was like, you really learn, a true leader learns how to delegate, which I'm sure you know yourself. It's just like, you don't really realize that you can't do everything. And that's really how it started. But really, I just wanted to be in a role where, I could show podiatry in a great light. And I think ASPS has allowed me to do that. And I hope everyone's proud of the work that I did with ASPS in the last 2 years, because I try to make it as, try to show that podiatrists and podiatric surgeons, in particular, that we contribute significantly to the healthcare system. Obviously, like I said, I could be biased because I'm doing a lot of the limb preservation side, but I also, my brother in there doing the trauma fixations and elective bunions and all of that as well, and elective forefoot and pes cavus cases too. Want to make sure they have a good light on it too in the community, and showing that they're contributing to the healthcare system. And that's basically what my role was, or my role is. I feel it's really for education purposes and to showcase podiatric surgeons in a good light, and not necessarily some of the stuff that we've been going on internally with our boards and all of that and other societies. But I don't really get into that.
Yeah, I don't either. But I think that's probably true of most professions. You just don't hear about it. We hear about it because we're within the profession, but I think there's lots of that stuff that goes on in every profession. So
100%.
So you're also vice president of the Save a Leg, Save a Life Foundation. Why don't you tell us what that's all about?
Yeah, so I've been, so it's AKA they call it by SAL, which some people call it whatever, kind of an odd acronym. But actually Desmond Bell, who is a podiatrist, longtime podiatrist, probably been practicing when I was in, I won't call him out too, when I was in elementary school or something. But essentially, he is the founding president of this organization. So I got approached by Des Bell, to be one of the new founding board members to get this done. Of course, right at the same time, I was trying to get ASPS back on the map. And so I told him, I said, I'll be a board member, but I definitely, don't take a leadership role. And of course, now my tenure as a leader, as the chair as ASPS was coming to a closure, I told him I'll take a more, a leadership role in SAL. But essentially, the reason why I like SAL is, unlike of the other societies that are out there, and not trying to knock them, is SAL is a public-facing organization. So what they do is community health screenings in areas of need. Most recently, the last one was in Dallas, Texas last winter. But we have 2 other ones coming up for the year 2025. We're going to do one in Arizona, probably close to the Native American territories in the Phoenix area. We're thinking about Detroit, which is where I'm close to where I'm at, and then another East Coast city. I'm going blank on it right now, but
yeah, that's okay. That's great. I think that kind of starts like boots on the ground. If you can get to some of these people before the snowball starts rolling downhill, you have a easier chance to make a difference when they stumble into your office with, necrotizing fasciitis. Well, not into your office, but they stumble into the ER I've seen it in the office. It's not good. But stumble into the ER with necrotizing fasciitis, that snowballs most of the way down the hill. The avalanche has started. So I think that's great. Starting the kind of boots on the ground and kind of getting the word out to those people that probably need it more than most is going to make a big difference for them. So let's kind of switch gears and talk a little bit more clinically. So I've heard you on some other podcasts, and people can look you up and kind of get your backstory, which I think is fascinating and fantastic. But for the sake of not rehashing some of that other stuff, let's kind of jump forward a little bit and talk about some of the clinical things that you see in your daily practice. So most of what you're doing is wound care and kind of limb preservation, all that stuff. So generally in our profession, the buzzwords these days is MIS. Everything is MIS. So what role do you think MIS can play either in the office or in the OR in terms of these limb salvage and wound care cases? Are you finding yourself doing some of that stuff?
So funny enough, so when I first got to the institution, MIS was kind of frowned upon, but it's interesting now that, I'm in the orthopedic department, and so several of the anything in the academic institution, whether, you're allowed to do it in scope of practice or not, you have to get credentialed on. So the way it is credentialed, because it's a new skill set. So even if the spine surgeon has a new robot, they have to get credentialed on it. So the MIS, we have two orthopedists that are credentialed on it. I'm hoping to be the first podiatrist to get credentialed on it so I could do some of my diabetic offloading procedures. Like you said, it's true, because the MIS, I do think it plays a large role in limb preservation, let alone when you're talking about pain relief for bunions and hammer toes, but a lot for these offloading procedures that typically you have to do open, hope that they heal those wounds by primary closure, sometimes secondary intention. You can get, you kind of one and done. You only worry about a stab hole of that burr in there and releasing it. And that's exactly the next step. So since I told you I just transitioned orthopedic department about a year ago, that's the next credential that I'm trying to go for, because everything has to be re-credentialed just the way how it works in academia, just because it's all about the proficiency in that particular skill set. But I'm actually signing up for an MIS training for 2025. But yeah, I think it definitely plays a role. And I wish, I wish that our profession would look at the MIS side, not necessarily more so for the bunion side, but also for the diabetic limb preservation procedures that we can do, such as metatarsal offloading procedures, hammer toe corrections, your bunion corrections for those, bunionette corrections as well for those procedures. I've seen people doing MIS real foot, which is crazy too.
Yeah, for sure.
Crazy in a good way. Crazy, like impressive.
Right. And even as simple as like a little flexor tenotomy or something where you're making just a little poke hole. I get some patients in my office. I don't do a whole lot of wound care, but these patients that have that significantly curved toe, hammer toe, claw toe, whatever you want to call it, the contracted digits, and they get that callus and recurrent wound. And I've got some patients who won't go for it. I'm like, listen, 5 minutes, I poke a little hole, we nick the tendon, that thing is straight, your callus healed. And the people finally go for it. They're like, oh, I should have done that years ago. Like little simple things like that just make such a difference to try to offload some of these things. Like you said, up to the kind of MIS, metatarsal osteotomies. And there's a lot of things that are kind of on the table in terms of keeping it minimally invasive. Obviously, these patients are high risk for complications, wound healing, infection. The smaller incision we can make, the better.
Yeah, I agree, exactly. And I do the flexor tenotomies in the office, 18 gauge or 11 blade or something like that for the semi-reducible or reducible deformities.
Yeah, super easy. Downside is obviously some loss of flexor strength.
Yeah,
but
that's to be the right candidate.
It's usually an elderly patient. We're like, hey, listen, we don't really care. You're not going to be dunking a basketball. We need you to get this wound to heal. Like that's our baseline that we're going for. So
agreed.
Let's say that we have a patient that comes in to see you, and let's just make it a generic wound, maybe a plantar first metatarsal head wound or a plantar hallux wound or something like that. For the younger people listening, what are the first things that you're thinking about when you just see this person initially? Let's go through kind of a fake patient workup and all the things that you're kind of thinking through when you first see a patient that has what appears to be a relatively simple wound, not a big midfoot Charcot infected thing. Let's put that on the back burner.
Not the crazy surgical ones.
Yeah. Let's just start with like a little simple wound. What is your thought process for workup for these patients?
So first I need to know if it's a diabetic foot ulceration based on a location, because I used to assume all neuropathic patients had diabetes, but that has been proven wrong. But so first thing is like, trying to find out if the patient has diabetes, when's the last time they had the A1C check. And if they usually say, oh, I had it, and I know my A1C is a 13, then I'm like, okay, at least we have somewhere to start as to why you haven't healed this wound. But then if they said they don't have diabetes or they haven't been diagnosed with diabetes, of course, I try to get in office, in clinic, point of care, A1C, just so I can see what's going on. If not, get a glucose. So because usually, based on the new ADA guidelines, 200 and above at any point, whether they're fasted or not, is technically a diagnosis of diabetes, right? So unless they've been drinking a bunch of, soda or pop, as we call it in the Midwest. So typically going on with that. So I, try to figure out the source. Most times it is diabetic. So if it's a diabetic foot ulceration, you're talking about, first I need to know the duration of how long they've had this wound. Usually most of them, if they come to me, they said I had a couple of weeks or a month, a couple of months, and then try to take it from there. Then of course, then I'm worried about, infection. So how deep does this wound go? So looking at it, if it probes the bone or how deep it is. Most times if they're seeing you for the first time, it's probably not going straight to bone unless they're in the hospital setting. Totally different type of patient that come in. So then also thinking about like their vascular status. So, checking their pulses, seeing if they have palpable pulses. If not, trying to get them into a non-invasive study like a Doppler or even an in-office Doppler if you have it there. Some people do TBIs in office, something like that. Or when I say TBIs, for the students, toe brachial index or ankle brachial index, ABIs. So trying to see if the vascular status of this patient. Then, of course, making sure they're not immune compromised. So a lot of my patients do have transplants, things like that. So that also could be another reason why they haven't healed, because maybe they're on some immunosuppressant drugs, rheumatoid factor drugs, or something like that I try to rule out before I try to just get straight to the business. Then, of course, you look at this wound, you want to debride it and look at it, make sure it's healthy, healthy wound, and then you start thinking about your dressings that you want to use. Typically, if it's a first-time patient, I'm probably going to a silver dressing or something like that, just because it's easy to get. It's usually cheap until we can try to advance it to some other therapies and try to take it from there. But typically, the biggest thing is making sure this thing's not infected where I need to send them to the hospital, make sure they know they have vascular flow, make sure they know if they have diabetes, because that has been, like I said, a recurring theme where patients don't even know they have diabetes or not. And then, of course, if it's plantar first met, like you said, it's most likely a neuropathic ulceration, so meaning they don't have sensation anyways. And there's other reasons why people could not have sensation other than diabetes, but we'll go with diabetes for today.
Yeah, for sure. So I think the important part there is the medical history of trying to figure out, like you said, establishing the chronicity. If this just developed, then we don't know if this might heal by next week. Probably not,
Exactly.
But it might. Or if it's been there for 6 months and it's been just kind of hanging out, well, then that tells you that that thing probably doesn't have a whole lot of potential to heal. Yeah. And then working them up from a medical standpoint is, the basis of medicine in general, but where podiatrists, utilize a lot of that medicine is in these complicated patients. And you interact with nephrology talking about, okay, their creatinine is tanking, and then they're on the renal transplant list, and then they're going to be on immunosuppressive drugs for life. And these patients get extremely complicated in a hurry. So I think the interdisciplinary approach between podiatry and nephrology, vascular, orthopedics, primary care, infectious disease, there's a big overlap here for these patients. So, I've always kind of thought about 3 basic tenets when I see a patient. I want to figure out, and you already mentioned them, just emphasizing them. Is there any signs of infection, vascular flow, and offloading pressure?
Yep,
and so those are the 3 kind of reasons, the things that I think of when a wound is there and it's not healing. I'm thinking of those 3 things: infection, vascular, and pressure. And then if we can control all of those things, we can generally try to get these wounds to heal. It doesn't necessarily mean we're going to keep them healed, because these patients are complicated again, and maybe their hemoglobin A1C is out of control and they have plantar prominence there, but they get extremely complicated in a hurry. So how do you, in your current job, value that interdisciplinary, multidisciplinary approach? Like, how do you guys handle that? Are you constantly referring patients back and forth, or how does that work?
I'm glad you asked me that question. And of course, yes, offloading is definitely key. That was one of the things I mentioned. I mean, of course, X-ray imaging too as well. So don't get, just for the students and audience, because sometimes as vets think we know, we think you already kind of went through that. But yes, as far as the multidisciplinary approach of taking care of these wounds, definitely I rely heavily on my vascular colleagues, and as well as my infectious disease colleagues. I mean, in my endocrinology colleagues as well. I mean, endocrinology, without them, I really can't get things healed. Yeah. So that's definitely a lot of referring. Luckily, so I do, like I said, I didn't really go too much into my practice types. So I do wear like an orthopedic clinic hat, which is like my podiatry clinic, where I see like young, healthy patients, some of my second opinion referrals, surgical consults, sometime my hospital discharge patients. But then I also have a wound care clinic where I'm seeing chronic wounds, new patients, second, third, fourth opinion patients, where it's just that. So yeah, and then in that setting, luckily I have an infectious disease doc in the clinic at the same time as me. So usually if I think it's something going on where I can't manage it, or I think it needs some IV antibiotics, she can come and see that patient. We're trying to get a vascular surgeon in there too, so it'd be easy just to kind of schedule for angiograms or non-invasive studies in the future too. But yeah, I agree. I mean, I'm spoiled. I mean, I do have pretty readily access to my multidisciplinary teams especially when I come across these very difficult patients, because like I said, a lot of my patients are sick, and the people that come to my institution think we have the magic wand, because we're, one of the tertiary hospitals in the state, but it's like, we don't, I have to lean on other people, and I have to lean on my orthopedic colleagues too sometime, to tell them, like, I don't think I could even do this. Like, we may have to do a BKA or something tomorrow, something like that. So definitely I agree and that's one of the many reasons why I like academia, but like I said, nothing's perfect.
Yeah, for sure. I mean, I've had in the past some vascular surgeon guests on, but I think vascular plays such an important role in trying to get these patients healed. And it can be very frustrating. So I practice in a place where vascular surgery is about 45 minutes away. And some of these patients don't have transportation or easy access to them. And I'm staring at this wound knowing darn well that this thing will not heal until we get you in with vascular and get some of this flow reestablished. I might have the results of ABIs or vascular or arterial ultrasounds or something, staring at this thinking, there's nothing. All I can do is try to keep this thing from getting infected until we can get you into vascular. So some of these wounds become maintenance wounds. I mean, your goal is obviously to heal these wounds, but some of these patients don't take that additional step that you know that they need to take to get this thing fully healed. And I see some patients that come in and say, I don't want to do that. I just want to keep it non-infected. I know I have a wound. I'll just live with the wound and go on my merry way. And I can't, you know,
Yeah, you can't. Yeah,
maybe I'll put them in the backseat of my car and drive them down and get them an appointment. But, you know, some of those things. So how do you draw the distinction between those chronic wounds that just won't heal? You know, those are tough. They become almost friends. You see them more than your family. You're seeing them so often that they're becoming, you know, send them a Christmas card. But how do you kind of manage and have those discussions with people that have the chronic wounds versus, like you said, considering amputation or moving to that kind of final next step?
yeah. So I like to call it palliative care, you know. So I almost feel like that's the hospice of wound care. It's like where it's like you're never gonna, you know, the only way this patient's gonna leave your practice is if they die out, which is kind of scary. And die out meaning whether it's amputation or you know, literal mortality.
Well, they're sick patients. Yeah.
Yeah, they're sick patients. So it's true. I mean, I have a couple of them. But what I do is I always try to make sure that I'm not being the most, like I am the captain of the ship, but what I do is I don't mind having other captains. So I'll have them go see a plastic surgeon that I know loves doing this type of stuff. And not necessarily chronic wounds, but maybe they're willing to do flaps or some type of, autograft or whatever they can do, split thickness, full thickness, grafting. And at least that I can talk to someone that they know, you know, that I know that likes doing this. And it's not just me just writing them off into the wind. Like, oh, Johnson just said, I can heal. I saw this guy and I trust them. So I always try to have them see another consultant with that. And then once we have that conversation, it's a little bit easier because it's like they go into, Dr. XYZ's office and now they're like, oh, he's telling me to cut this off. And Johnson had already told me that months ago. So it's like now we can have this conversation about, do you want an amputation or do you know this is just me playing defense and you just have to live in my clinic and you and your caregivers kind of accept that. And that's the conversations that we have. But it's true. It's a tough conversation, but it does make it easier when another person or another surgeon has weighed in on it. So much easier. And and that's why even if I tell those docs that's in the community when I'm giving out lectures, I'm like, have another doc that does the same thing as you. See some of your patients. Don't be afraid to have refer them out for a second opinion and thinking that, they're going to steal them away or something. Because you want to have that because, especially from a legal standpoint, it looks better. And it also does, it builds camaraderie with the community too.
Yeah, those are extremely hard conversations to have. And in my mind, there's kind of two different types of patients. There's the patients who just have a chronic wound and it's just the wound is just there and there's nothing really that's going to get this to heal. Or maybe you've had it heal and it's recurrent, just keeps coming back. And it's just this frustrating wound versus some of these patients have like chronic low-lying infection. I've come across patients in my past, especially in residency, who ended up with an amputation and said, I instantly felt better, because they have this low-lying chronic infection that was just lingering throughout their body. They didn't realize how chronically fatigued and just ill they had been feeling until they underwent amputation. I'm not saying amputation is the answer, but I'm saying sometimes amputation is the answer and they don't realize it. So especially back in Pittsburgh, we would have amputation support groups where we would have people come in. You'd have a therapist come in, you'd have a surgeon come in, and you'd have a couple of people who'd underwent, and the prosthetist who's going to make their limb, and a support group of people who've had the amputation and have let people see what it's like to have undergone this significant. Because sometimes I think the reason I'm harping on this is sometimes amputation feels like failure, or we connotate that with failure. It's not necessarily always a failure. Sometimes that's a foregone conclusion. You don't know it at the time. sometimes you try your best and you're going to heal this wound. I'm going to put on this product and we're going to do flaps and we're going to offload and we're going to do all these things. And then they get infected and get an amputation. It feels like a failure. Well, that was probably a foregone conclusion. You didn't know it at the time. But I think preparing these people for the potential for that down the road, and anything that isn't amputation then certainly does feel like a success. So I think that's an important conversation to have with these people, especially if you're doing these complicated reconstructions, offloading, wound care. That's kind of, what are your thoughts on amputation of do you think it's a failure? I obviously don't, but do you think it's a failure, or do you think it's just kind of one of the things that comes along when you play this game?
Oh yeah, so definitely it's definitely not a failure. So short, I'll end the suspense on that for the audience. Definitely not. I don't see it as a failure. I mean, and I live in this world. I mean, if and I actually win more than I lose, but I do lose, and I do count the wins and losses. But it doesn't mean that I feel like I truly failed, because some patients come back and they thank me and say thank you for letting your orthopedic colleague cut off my leg, or letting your vascular colleague cut off my leg. Because you're right, they do feel that because antibiotics is not, I don't know if anybody, like a lot of our, our people and people in our profession haven't been on antibiotics for a long period of time. And that does not feel good, like being on it, whether it's the oral or the IV, it does something to your gut flora that just does not make you feel healthy and have that energy that you normally would have. So even that, just the fact that they end off of that, they kind of get happy. And then especially the patients with dialysis who are already spending a lot of their time outside of the home and dialysis center has to then go to a wound care center, they're happy too, because they kind of have somewhat of their life back, because they already lost part of it going to dialysis, and now we're spending the next half of it at the wound care center. Basically, they're just living at centers. They're not actually living their life. So that's another thing. So they get that aspect back. But I don't look at it as a failure. I think I pitched. I just had so I have two things I'm gonna say. So one, when I was a resident, I had a chief that used to say, "Save a limb." He was a "Save a limb, lose a life," and I used to like. He's like very cynical, but he's right. So he's like, good job, AJ. You saved this person's, mangled foot, but they can't even freaking get in the shoe, that's the thing. And he's doing it to make me feel bad, but it's like, it's true though. He's right. He's like, I probably should have just pitched a TMA or something, right? Like instead of having them have this 3, 4, 2.5 toes that they have or something.
Yeah.
So now they can't even really get in the shoe or can't create a prosthetic. So it's true. So you
be a Texas fan. Look exactly. Horns.
I've done that too. It's mostly in residency. I don't do it as an attending now. I'm like, I can't. I think I have one guy that I have it like that, and he has no flow for a TMA. But so it's like that. And then of course, so that's the one thing is save the limb and lose the life. So they really don't have a quality of life. And then of course the amputation can be a solution. So also always some of my patients tell me I could be a used car salesman, because it's like, you pitched that amputation great. Because I'm like, yeah, I can tell you that, you've already, like some of these patients have, heart transplants. They've been stuck in the hospital on and off for a year. I'm like, do you really want to deal with this chronic wound and come to my clinic every, 2 weeks? You can live with that life. And like I said, financially, I benefit from it. And then I may heal you or whatever. Or do you want to get this amputation and go about your life, And most times they'll bite the go for the amputation. So I do play both sides of it. I mean, do I want to save every limb that walks in my door? Yes. But I also want this patient to have a quality of life that's going to be worthwhile, not just kind of zombied out, going to center to center, infusion center, wound care center, dialysis center. That's crazy. Like, even for me, I'm like, I don't even know if I could do it. And I commend those who go through it, some of that regimen with me.
Yeah. Yeah. That's well said. Let's talk for a minute about some wound care products. Not necessarily, I mean, you can mention trade names, I don't care. But, let's talk about maybe the overarching, we don't have to go down the path of 10,000 different things, but, I think sometimes it depends on what you have available in your office or your wound care center. But what are your kind of thoughts on what you like to use? Are you using ointments, creams? I guess obviously everyone listening knows it depends on the wound, depends on the drainage and the exudate and the infection, all these things. But maybe some broader ideas of, I like to use an alginate. I like to use a, Santil if it needs debridement. What are your thoughts on those type of things?
Yeah, so I mean, if you're right, every wound is different. Sometimes I try to be the wound whisperer and try to figure out what this wound wants me to put on it. But I do use I don't use as much silver products as I did when I first started practicing, only because I will say silver is great at the beginning of the wound healing process, like as in like you said, like how we did that scenario when the patient first comes in and I want to use it. But if I use that for months and months, silver can become toxic and create cell motility problems. Then actually that could be preventing you from healing the patient. So I try not to rely too much heavily on my silver-based products, but I do use alginates, typically just, calcium alginate or something like that. And then I'll use some silver alginates. I am pretty big on what they call SAP dressings, so super absorber polymer dressings, typically because they're pretty insurance friendly. So they give you those 30-day coverages, and they're similar. Basically, they're a souped up foam dressing. But what it helps is I notice anything that that's chronic usually has pretty large amount of drainage. So the drainage that if I can manage drainage and I can use these saps, then if a patient say, oh, I forget to change the dressing, blah, 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 the sap kind of protects me. And also use copper-based dressings too. There's only one copper dressing in the market right now. So it's Med Copper. I like that. It's a great product. It does very well. I mean, I've seen it do miracles on patients, and I hate to even overstate it, but it's just the truth. And I'm not talking about miracle healing, but as in this patient used to change this dressing 3-4 times a day, and now I don't have to change it two times a week or something, So now it's they're getting their quality of life back, especially for the caregivers. If they have to change dressings 3-4 times a day, anytime they have to just get away with one dressing change a day or 2 dressing changes a day, then you already kind of help everyone's quality of life involved with this wound. So I try to get those type of dressings. I do use my Santos. I mean, I use it a lot on my postoperative complication patients because a lot of them end up with fibrotic tissue or something like that. And then, of course, I am heavy on the skin subs. Use pretty much all the big portfolios out there. And I'm not married to one particular company. I mean, I consult for a couple of the different skin sub companies out there, mostly dressing companies. And but I don't even... I tell them when they come in too, I'm using whatever I need for this patient that walks in. And it's weird. I wish I had a silver bullet. The only silver bullet I really have is sap dressings. If anybody's doing some type of rural or urban care practice, I would say use those sap, which is the super absorber polymers. And there's different brands out there. So it's not necessarily the brand that I consult with, but I would just say that's probably the only silver bullet that I have. Everything else is clinic-based and judgment of the patient and affordability, because some of these dressings are really expensive.
Yeah, they can be, especially the skin substitute products.
Oh, yeah. We could spend a whole podcast on skin subs in the politics of skin subs.
Yeah, and bore people right to death with all that stuff.
Well, it depends. I don't know if you read about that one, this one illegal case where this person built out this skin sub company or a distributor of a skin sub it was $2 billion in 16 months or something crazy. Yeah. It's crazy. I'll send you the article. Illegal bill. Obviously they're facing federal time right now.
Yeah. There's a lot of, it's complicated. I've always kind of had this weird relationship with wound care in that we want to heal the wounds, but if we heal all the wounds, we have no patients. Which obviously you're never going to heal all the wounds because there's going to be a new inflow of people getting diabetes. In a perfect world, nobody gets diabetes, nobody gets a wound. We've healed all the wounds. We all, go along our merry way.
Exactly.
Yeah, we find something else to do. But it's a little bit weird to me. It's like, hey, we want to have these patients, but we want to heal them, but then we won't have patients anymore. But I think some of the younger people listening, one of the most difficult thing is trying to figure out which products to use because the rep is going to come.
Yeah, it's influence, right?
There's so many products, and they're going to come to your office and be like, look, we have this study that we showed that we were better than X, Y, and Z, and maybe it is, and maybe it isn't, but maybe it's twice as expensive, so I could put on, or 10 times expensive. I can put on 5 of these grafts for, less than year 1. So, it just gets so complicated in terms of using all these and figuring out when it's appropriate and how it's appropriate. How often do I put them on? And, the research is so all over the place because it's hard with any one specific wound. Is it a pressure wound? Is it a vasculopath? Is it a transplant patient? These patients are all going to be a little bit different and they're going to have different outcomes. So they may need different products, but I found that so kind of tricky when you're getting into wound care because it's you want to be able to say, when we do hardware fixation, we're going to say, oh, I'm going to put a plate on. I'm going to nail that. Well, in this, it's not that simple because maybe there's 50 different things that would work okay. Maybe one works a little better than the other, but I don't know. I just get overwhelmed with some of that stuff sometimes. But let's talk about wound vacs. What role do you use wound vacs for?
Yeah, so I like wound vacs. So wound vac is an interesting product too because if you look at the history of wound vacs were only supposed to be used for inpatient use, and then of course it goes back to financial incentives. We use it for weeks and days, over weeks, sometimes months. But essentially,
Mm-hmm.
what that wound vac was doing was getting the wound to boost into that the next proliferative phase. So technically, when wound vacs first came out, we do our surgeries, we put that wound vac on during the surgery, or maybe afterwards after you make sure it's not infected or there's no acute bleeding going on. You have it going on 2 to 3 days. You boosted that patient up because now that's what the wound vac kind of got that wound revved up, and they go about their life, and you do whatever wound regimen you're going to do. But then they realize, oh, we should create these smaller wound vacs to have patients take and carry around for weeks in and weeks out. But I mean, I think it's great. I mean, wound vacs, there's some docs that only use wound vacs for these surgical wounds. So I do, like you asked me when I use them, mainly for surgical wounds. And sometimes my chronic wounds become surgical wounds because either I'm debriding a large amount of tissue, it has a lot of probing or depth to it, or maybe I did a resection and I can't close the tissues or get a flap or get one of my plastics guys to put a flap on for me, and I need some granulation quickly. Otherwise, this entire leg is in jeopardy, and that's why I do the wound vac. But wound vac, I think, is tried and true. I think it could be a gold standard. So you asked about a gold standard, because that's basically what you're going to. Is like, we know screw fixations gold standard, plates gold standard, and we can know how long we can give them predictability. Wound vacs, you can get some predictability with, depending on if you got the infection under control at the time that you started. And so I'd like it, and I think it's great. It's true. It goes back to, now you're talking about a competitive market where it used to be only one wound vac company. Now there's probably 4 or 5 penetrating the market. Is it the technology the same? I don't know. It's like, it's true. I don't really know. I still go with the tried and true, first one to enter the market, just because the consistent results. But I love wound vacs. they definitely get, especially surgeons. It gets us out of really tight positions, especially these post-operative complication patients that we have to go back in, the Roma surgeries where there's dehiscence or some craziness going on. That is where you can really redeem yourself with the patient and hurry up and get that closed so you don't look like you botched it or something.
Yeah, for sure.
So,
I want to talk about one of your research projects that I find really interesting, and I want to get your kind of input on that. So specifically, it talks about skin pigmentation impacting clinical diagnosis of wound infection. So,
yeah.
And the role that bacterial fluorescence plays in all that. So, why don't you explain kind of what the idea behind that, and then
Okay.
how we can kind of do a better job at treating these patients.
Yeah, so that's a good study. So that was a moleculite study where we took a data set that was already existing and looking at, so moleculite for the audience, does, essentially it's a fluorescent camera. So you look through it through a camera and it shines a light onto the wound. And based on the colors that appear on the wound at the time, you'll know it could be the wound or peri-wound, that should be specific. Based on the correspondent fluorescent lights, you'll know if there's bacteria present or infection present. So yes, essentially what happens is what they did was we went back and looked at the data and looked at patients that had skin pigmentation of variety types based on the pigmentation classification. And basically, derm is for skin pigmentation classification is not a real true thing. It really is based on how well how well you burn, essentially. So that's really how it goes. Can the skin tan versus how the skin doesn't tan? That's really how it goes. But we brought a derm on board, a podiatric derm, to clarify that for us. So what happens is, essentially, so when you scan, so let's say we have a patient come in the ED, you have a patient with a darker skin complexion, and they say, oh, I got this chronic diabetic foot wound. I've had it for XYZ time, and it's like, I don't feel well. So you go in, you look, and you're like, when I took, Miss Doctor, was like Dr. Malay, when I was in Dr. Malay's office, he told me, look for redness, look for swelling, look for odor, feel for temperature. And he goes, I see this guy with this darker skin. All I kind of see is temperature. I don't really see the redness. There's no odor. There's no drainage. How the heck do I know this guy is infected? Because it's not what I was trained on. Hits, you can pull out your moleculite, and it can't, it's non-biased. It doesn't, it basically bases it on the presence of the bacteria that's there in the peri wound, and it can light up and tell you this is cellulitis that's there. And that's kind of how we went about that project. So what we did was we blinded the judges on it and went back and seen how could they tell just based on a clinical picture, if this was infection versus the fluorescent picture, if it was truly infection. And essentially it was like 70% of the time the people missed it. Even I would miss it. And and I have darker skin. Even I sometimes miss it because you can't tell the cellulitis because the pigmentation hides it. And so basically the fluorescent light is, the magician behind it is basically seeing something that you can't see with the naked eye and essentially helping you not miss diagnosis of like a cellulitis or an infection based on skin pigmentation. So basically it's the equalizer. And so we're just trying to look at it in different roles, various roles. Molecular light isn't cheap. That's one of the issues too. So you may not have one at an ED near you, but just thinking about that fluorescence aspect of it in skin pigmentation. How many of these do we miss? All of us, just coming through the ED or coming through our office and end up with higher morbidity and mortality because these wounds have gotten enraged and they don't present the way we learn in textbooks or atlases.
Yeah, that's what I was going to say, is that I'm sure the data is out there in certain subsect of populations that we're missing more clinical diagnosis of infection in certain populations that becomes more difficult to evaluate that. So I think that's interesting to kind of get, like you said, something that's an equalizer. Obviously, we have lab values. We have some other things we can do. But I think trying to make it an equal playing ground in terms of trying to figure out, at least right away, figuring out which ones are infected is pretty awesome to have that.
Exactly.
Speaking of further imaging, what are your thoughts on MRI and the role it plays in inpatient management of infection? Do you think we overutilize MRI? Do you use MRI? Does it change your treatment algorithms? Or because every time I have a patient in the hospital, they're like, "We're getting an MRI." I'm like, "Well, I was gonna open it up anyways. I don't need an MRI because it's gonna look very different. As soon as tonight, when I open it up, it's gonna look different, and the MRI is now useless." So, what are your thoughts on that?
I know. I feel like I don't know if it's regional, but it's true. I mean, we love the MRI so I have to incorporate it in my algorithm because I work with residents and fellows, but it's true. It's like you can't. But the problem is, what if the MRI machine's broken? All of a sudden, everyone acts like they don't know what to do. So then, of course, I'll order like a CT with contrast or whatever.
Yeah.
But it's like the MRI is costing more money, as in like not necessarily. I mean, the MRI does cost a lot of money, but as in hospital bed time, right? Because it's like if I could just go in, do my thing, based it off, my clinical findings, but I almost feel like it's a legal situation, right? Because it's like that one time you didn't go resect enough bone because the MRI said it was there, then that could ding you. So I feel like it's more of a legal aspect, more so than a clinical judgment. Because you're right, I can't really think. I mean, I could, like you said, maybe 15% of the time where this MRI is actually helping me surgically figure out how to manage this osteomyelitis. And that's why for the students, we're usually looking at it to figure out where the bone infection is ending or where it's at, or if there's even bone infection there. Because sometimes you're right. Sometimes the MRI I could clearly see there's infection when I walk into the room, and the MRI will say there's no infection, which is crazy, So it's just, I think we do overutilize it in inpatient, and I think it's really time consuming and expensive. And I would favor even more so CT, plain CT or CT with contrast, to be honest with you. But, everyone thinks I'm crazy when I say that. And actually there's newer studies that were ultrasound, because ultrasound tells you quicker than anything.
Yeah. Yeah, I agree with you. I think we overutilize MRIs. So I don't know that you're ever going to be, wrong to order an MRI, but I don't know that it's changing anything that I do.
Is it really giving me better outcomes? Or, I don't know.
Right.
Like, it's just, I feel like it's sometimes it's really slowing down the train. And maybe that could be why we have our, because, they harp on podiatry about keeping our patients inpatient too long, but I try to, get them moving as quick as possible for their own safety, because you're right, the longer they're there, most likely the more complications they have, and vice versa. So
for sure. I want to talk about, I looked it up. It said Michigan virtual reality surgical interaction. So what's the deal with that? Is that kind of like virtual reality training, or what's the story with that?
So that's my vision. You're talking about my vision. Yeah. So my vision, which is my virtual reality project that I'm working on. So essentially, there's a company called Immertech. So I could just, that created this, I would call it's a software. So it's a software using hardware such as like Oculus, or even you can use it on a laptop computer. But essentially the software, what they do is, let's say, like you said, you wanted to teach me about MIS surgery, and you're like, I got this new burr I want to show you. So what happens is you'll have your OR scheduled, and you'll say, Johnson said he doesn't, do enough MIS. I want to teach him some stuff. So they'll send me a headset, an Oculus headset, and I literally will be in your OR and we can interact. So they have a VR camera, 360, live chat. I can see the x-rays, the live fluoro while you're doing it. Even could see vitals if I needed to or whatever. Usually for our cases, we don't need vitals. Like, not for that stuff. We just don't know, but you could have it if you need it.
Keep them alive. That's all I care about.
Yeah, that's what I'm saying. Yeah, usually we're not doing anything that's causing blood pressure problems most times or heart rate problems. But so typically, let's say, and I could literally be in your OR virtually and see it from the point of view of the VR camera or even the cameras that's in the overhead lights, and essentially watch the surgery. So that's how they pitched it. But I was like, I think that's great, the live stream and whatever. But I was like, what if we created like a repository of surgeries for attendings to show the residents and fellows? And so that's what my vision is. So essentially we'll start it off with the foot and ankle orthopedic department, which is our division that I'm in orthopedics. So we'll have right now I'm working on the cybersecurity aspect of it. But once I get past all of that, we'll have them come record us in our surgeries for about a week or so. And then they'll edit down our surgeries, and then our residents and fellows will know some of it. But the goal is to try to get some of the key cases that we normally will do, and they'll watch it to see if it helps them be more prepared. Especially in orthopedic cases, we know a lot of those, most of the cases positioning, right? So even the positioning will be recorded as well for those learners. And essentially just trying to see how to incorporate VR into learning for medical and surgical education. And so I pitched it to Immertech. They thought it was a great idea. Pitched it to the university. They gave me some money to get it done. Now I'm just going through like the whole security side of it, because there'll be patient identification. We got to blur out things like that. But it's going to be great. It's going to be great. And I recommend, I don't even get paid by Immertech. I recommend people checking it out. It's great stuff, great learning. So I'm trying to get them into like the mid, or get the technology into the mid education space, because I think VR plays a vital role, especially for us. We never know, especially if the residents or the fellows, depending on, in Michigan, the residents do 60-day rotations. But when I was a resident, we only did 30-day rotations. So you never know what you were going to see in that 30 days when you're rotating with that attending. So try to help with some of the consistency of getting the case exposure, but also spending less time on like learning what that attending does. They can just watch what that attending does in action in VR. It won't be real time, but in recorded time, and kind of be more prepared in spatial awareness, where they should be positioning, where their hands should be, where their body should be, things like that. So that's the goal of it.
That sounds cool. That sounds like a really interesting project. So we'll have to keep an eye out for that.
Yeah, it's cool. I think you'll like it.
For sure. Well, thanks for joining me tonight. I think this was awesome. I think this will be real helpful for people and kind of getting a peek into what you do. You're everywhere. I see you everywhere.
Like I tell, I'm trying to make podiatry sexy again, man. That's all.
There you go. You're doing it.
It's a fun profession. I want people to realize it, and it does great for me and my family.
For sure. Me too. So thanks for joining me. I appreciate it.
Thanks for having me.
Yeah, absolutely. So this is Jeff Dykes on Paw Patrol. Thanks everybody for joining us. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.